All right, people, it is 10:03 a.m., 6/13/2023, the year of our Lord. It's our favorite day of the week. We're going to do some advanced physiology and pathophysiology. Before we get started today, though, I wanted to scroll through our syllabus here. By the way, I got a gold star on my syllabus. Got an email, I guess it was maybe toward the middle or the end of last week, and it says your syllabus is a gold standard syllabus, and I was pretty proud of that. And it gave a list of all the teachers who had gold standard syllabi, and I was scrolling through it, and I think it was pretty much every teacher that's employed at Belmont Abbey teaching for the summer. And I didn't feel as good about it after I saw every single name was on there, but still, it's nice, because it could have gone the other way. It could have been one of those places where you work and they only publish the names of the people that messed up. So I like the direction they're going. It's very optimistic. So as we scroll through my gold standard syllabus and we get down to our schedule right here, we're going to go ahead and break schedule, in the next couple of weeks. It doesn't take long, these things. They're made way before we actually start doing anything. And there's a little caveat that we usually put on the syllabus somewhere, kind of hidden, says the syllabus is subject to change at any time, just so we can do this. But our upcoming test is going to kind of stay on schedule here. Today, we're going to do autonomics and endocrine, kind of finish up our neuroendocrine stuff that's communicating and coordinating in the body. So endocrine is a good fit in there. And I think endocrine goes well with autonomics because we're kind of taking out some of the voluntary stuff here. Obviously with neurophys, even neurosensory, there's some somatic portions to it. Like you can pick up touch and pressure and proprioception and itch and burn, and you can control skeletal muscles. So that does take up a lot of the discussion, but a lot of things that are happening in the body homeostatically, at least, we don't have any control over that. I mean, I could exercise if I wanted to warm up, but the body has other means of regulating body temperature, right? And so when you do autonomics and endocrine, it's kind of taking care of all the stuff that's kind of in the background running all the time, taking up all your RAM, if you will, trying to maintain homeostasis. So those go good together. And that kind of ties everything in for our first exam. So a lot of neuro, autonomics, endocrine. So this will kind of remain on schedule. But as we get into cardio-phys, I mentioned this to you initially that we did have blood immunity and lab diagnosis is going to be something that you'll end up using quite a bit when you start working, where we're going to look at certain levels of things in the blood, not necessarily just a CBC, but a CBC plus maybe metabolic panels, or, just certain electrolyte numbers and stuff like that. And we're going to memorize some normal values. We're going to go ahead and let the computer remind us of some values eventually, where we're not memorizing them, but we know what they're for at least. So if I end up seeing too high an amylase or too high a lipase, maybe I'll think pancreatitis. Or if I see too high an ALT or something like that, I might think hepatitis or some type of liver problems. And I think I mentioned to you before, we're probably going to do that test separately. So as I was kind of looking at the schedule this morning before class started, what we're going to do for our next test, and I know you're probably not all that concerned about that right now, but just to give you a heads up, once we get done with our stuff today and this week, we're going to have a Q&A on Thursday. So that's what the test review is going to be. I'll join Zoom with you on Thursday, normal time, 10 o'clock in the morning. And I'll take any last minute questions that you might have over neurophys, neurosensory, autonomics, or endocrine. Basically, it's just preparation for our first exam. And once we get done with that this week, I'm going to start to kind of retool the upcoming schedule. So we're going to keep cardio-phys. We're going to actually work on that for a whole week. It's the same PowerPoint. It's just, hopefully we can pull some of the patho-phys out a little bit separately, but we'll see. We'll see how it's going to work. But we're going to work on this for a week. We're going to work on blood flow and pressure, which gets into, again, capillaries, arteries, veins, how they're different. One set diverges, one converges, and some are more distensible, and that gives it certain properties. So that's what blood flow and pressure is about. It also talks about like vessel tone and how that contributes to homeostasis, keeping blood flowing in the right direction, keeping blood flowing, period. So if I don't have, shock, if I'm not in some type of anaphylactic shock or I don't go into shock, then blood should always flow from the arteries to the veins back to the right atrium and so on and so forth. So we'll talk about that with blood flow and pressure. Respiratory system and gas exchange kind of talks about not only the basics of the respiratory system, but again, gets into respiration as a whole, gas exchange between the cells and the blood, diffusion of those gases from higher concentration to lower concentration. What happens if the space in between, say, the alveoli and the capillaries is too great? How would that change our rates of diffusion, and what ends up happening to the alveoli? Why do we have cough and sputum production with left-sided heart failure? All that wonderful, wonderful stuff we're going to prepare for, and then kind of keep that together all as one test. And we're going to kick blood, immunity, and lab diagnostics out. So again, that's what I'm going to retool. We're going to have this as a separate exam. And by doing that, that might mess up our schedule a little bit, where I had planned for us to do muscles, urinary, digestive, liver, cancers, and neoplasms. So one of these might get kicked out. I haven't determined that yet. I mean, obviously, it's not going to be urinary. It's certainly not going to be digestive or liver. We're going to kind of do those together. Cancers and neoplasms, I'm just going to do a top 10 of those, so that way we're familiar with them. So muscles might get kicked to the curb. I really don't know yet. But at the same time, when I was looking at the schedule this morning, I think I might do the final as open notes or open book, where I think we're going to do a more comprehensive kind of package. And I'm literally going to let you look up answers if you want to, but it's going to be pulling from multiple chapters because I think that'll be more beneficial. So again, I'm not so concerned about what grades you're making in this class as much as I'm concerned about how much you're actually learning from this class. And to optimize your learning, we're going to have a couple of normal tests. The first two tests for sure, neuro, cardio, and respiratory. These are normal tests you're going to study for. Do as well as you can. You need this information to be kind of right on the tip of your brain. You need it to be fundamental. You need to be able to recall it anytime, right? Because if I see something in a patient, it's indicating there's an upper motor neuron lesion. I need to know that there's pressure on the brain or the cord. You need to know that stuff. Cardiovascular, if I got the pressure dropping, what can we do to fix it? You need to know that stuff. Urinary, we definitely need to know that stuff. That's why we're going to hit it for a whole week. We're going to try to do as much as we can with urinary. It's a lot of review of the same basic, functions, like what does different parts of a nephron do? Like what's a glomerulus do versus what does a tubular system do? What happens if the glomerulus is inflamed though? What happens if the tubular system is not working, right? So, maybe we can make some determinations about what part of a nephron is broken. And certainly the renin-angiotensin-aldosterone pathway, that needs to be automatic in your brain. Like what's the role of aldosterone, and, what would happen if I have too much or too little aldosterone? So we'll even talk about that today a little bit with the endocrine. But urinary, in my opinion, is one of those great chapters where it ties in all physiology. Because if you have a system here that has something to do with fluid volume, blood pressure, right, electrolyte balance, urinary has basically control of most of that stuff. That's everything. If my electrolyte balance is off, then everything's going to be off. My nerves aren't going to work appropriately. My heart's not going to work appropriately. My muscles are not going to work appropriately. And one of the most sensitive muscles in the body to electrolyte changes is cardiac muscles, because they're very dependent on ECF ions, so the way the heart works is different than skeletal muscles. It's usually leaking in certain ions like sodium and calcium from the blood in order to time itself, to have its rhythm, right? It's autoregulatory, and that's based off normal homeostatic electrolyte levels being appropriate. So If we talk about that type of stuff back in cardio, hopefully, then maybe we can get rid of muscles. But ultimately, since we're doing urinary down here at the bottom, I think what we might do for the final is do it in a more comprehensive fashion, maybe do quite a few patient presents with type questions like PPW, patient presents with high levels of this on the lab, right? Fluid volume might be messed up. So maybe they have high creatinine, they're retaining fluid, they're hyper or hypo this or that, what's wrong? What would you think is wrong with a patient? And by keeping it open book, it will allow us to do a comprehensive exam, even in a short summer semester, but it'll help tie in everything together. And that's the whole point of this class. The whole point of this class is not meant to tax you during the summer, just to give you an extra course so you can memorize a few extra tidbits here and there in the hopes that you carry that along with you. It's literally to teach you how to use all this stuff. So eventually when you have a job, you can know when you're supposed to give them this and know when you're supposed to give them that. And if I do give them this, what could possibly happen with it? Like if I give that patient insulin, why are they hypokalemic now or something like that? You know what I mean? So things that you might not have thought of before end up happening. And then how could I go and treat that maybe? So that's my thoughts. So again, it's kind of up in the air right now. Everything's going to be as hopefully useful as humanly possible. But again, our first test isn't going to change. This is going to be a normal test. That's what we're going to prepare for today. The next test will change a little bit because we're going to kick blood, immunity, and lab diagnosis out. This will serve as its own standalone test right here. So we'll end up having a test here with cardio, blood pressure, blood flow and pressure, respiratory system, and gas exchange. So this will be lecture test 2. This will be a third test, maybe not as many questions, maybe like 30 questions or something about lab di. And then our final exam, which may or may not include muscles or something like that, we'll probably do more comprehensive-ish, but keep it open book where you'll get like 3 hours or something like that. So again, it'll tie everything together, but it'll allow us to do more patient presents with type scenarios where I'm not just asking you multiple choice questions. We can throw in lab di, we can throw in urinary and cardio all together, right? All that stuff. I think that'll work best. So anywho, let's worry about the problem at hand first. Today, we're going to finish up our first exam material. So exam 1 covers fluids, which I know kind of hidden back here in the beginning. Tend to forget about it until now. But it's going to cover fluids, neurosensory, autonomics, and endocrine. So basically from week 1 up until week 3. This is today's meeting right here. So after we get done with autonomics and endocrine, I will post our Zoom recording here. On Thursday, this is basically a Q&A session. So for our Zoom meeting, it just says, join me if you have any last minute questions. So if you have questions, join me. If you don't have any questions, study. I don't care if you join or not. It's completely for your benefit. So I'm not going to look down on you if you're not here, but that's what Thursday is going to be for. So on 6/15 Thursday, it's a Zoom Q&A session. I'll get autonomics and endocrine done today, even though I keep talking. You probably think I'm really not going to get it done, but it's a lot of review. A lot of it's review. I didn't know we were going to have a pathophysiology class this soon. So a lot of what I did in endocrine previously, I already went ahead and put in the pathophys. So that's still there. And then I separated it out and I put it toward the end. So a lot of review today. And if you didn't have me, that's fine too. You'll have the entire PowerPoint and it's pretty straightforward. Once you see how one hormone works, all the rest of them work the same. It's not a hard study really. But our first exam, tentatively, we want to try to get it done by June 18th. So lecture exam 1, once you click on it. For you, your view will be a little bit different than mine. So let's click on student view real fast. Yours will have a take the quiz button. And they used to be green. I don't know if yours will show up green or not. Don't hit it if it is. But it'll say take the quiz or start quiz. right? And once you hit that, the timer starts. So make sure you read the instructions. It's pretty straightforward. It says this is an exam that covers this amount of information. It's 50 questions. You'll have 50 minutes to do it. So about a minute per question. In this test, it's not open book. Learn it. Make sure you know the material because you're not going to have enough time to go and look up stuff. That's the whole point of having a time quiz. So once you start, the timer starts and it's going to say 49:59, 49:58, 49:57. You can't stop. So that's why it'll say, do not start until you're absolutely ready, because you can't pause it. And if you click out of it, the timer keeps going regardless if you're on the page or not anymore. And also, I don't want you looking up things, and I can see if you do look up things, so just don't do it. I'm not going to get mad at anybody because sometimes the whole reason you're probably cheating is because you really care, but you need to know the information. So don't look up stuff. I'll be able to see if you're changing screens or looking at different stuff once the quiz starts running. But just make sure you're ready for this one. Again, do the best you can. So once you're fully prepared, take the quiz. Take the grade you get, learn from your mistakes, and move on, right? So at the end, you'll be able to improve your grade, plus you'll have papers you can turn in, plus we're going to have another short test at the end. So learn what you can learn from it if you don't learn it all, and keep moving on. But again, make sure you've studied completely before you hit the button because it will be timed. So nothing new there, I'm sure, for most people. Try to get it done by the end of the weekend if you can, so that way we can start fresh next week. And I will, once we get past Thursday, I'll go ahead and start populating these next modules. You can't see yours yet because I haven't published them yet, but we'll have cardio phys a couple of times next week, right? Do blood flow and pressure, respiratory system and gas exchange, and that'll pretty much be our material for the next test over weeks 4 and 5. So if you get lecture exam 1 done by June 18th, this is 2 days later, you'll have a fresh start. If you get it done the 19th and the test is closed, email me and I'll open it back up. But again, this will keep you on the best schedule right here. So anywho, it's a lot of instructions. Let's go ahead and do this. All right. So I got my autonomics and endocrine open already. I'm going to go ahead and switch screens over. So, start with autonomics. Pretty straightforward stuff, right? Same stuff we used to do before, even though we're looking at the page, and I just took the time to switch screens. I'm going to go ahead and turn it off. Let's do our little chart we usually do with autonomics. So autonomic nervous system, same as before. It's Oscar. Oscar's with us again today, people. I have a plan though. If he starts to get out of control, we have frozen puppy cups in the freezer. I'm going to get one of those rascals out. It usually takes him about 30 to 45 minutes to lick that thing down anyway. So I think we're good today. But autonomic nervous system, 2 branches of that. You have the sympathetic division of the autonomic nervous system, which we'll usually just call the sympathetics or the sympathetic nervous system. And you have the parasympathetic division of the autonomic nervous system, which we'll usually just call the parasympathetics. And what makes something sympathetic is it's responding in the presence of stress, and it secretes norepinephrine. And since we're going to be doing both autonomic nervous system and endocrine today, we can just go ahead and put epinephrine in there as well. Because in larger states of stress, rather than just sending a bunch of individual connections out from the lateral horn of the spinal cord to individual target tissues, we can just send a signal to the adrenal medulla, and that can put it all in the blood at once, and then we can have a more global sympathetic response. So we're just going to go ahead and throw that in there. But normally, if we're strictly dealing with nervous system, then of course norepinephrine is your neurotransmitter. Parasympathetic, your neurotransmitter is going to be acetylcholine, and both of those are what we call postganglionic neurotransmitters. So that'll get discussed once we get into the notes. In order to receive norepinephrine, though, on the target tissue, you're going to have a receptor site that can read norepinephrine or pick up norepinephrine, like the shape has to be complementary. So we are going to use what's called adrenergic receptors. And to receive acetylcholine, we're going to use what's called cholinergic receptors. And I'm sure you've, again, heard of these things before, or if you're further advanced, you're already talking about anticholinergics or adrenergic mimetics or adrenergic agonist or antagonist or something like that. So obviously that's what it's referring to. It's referring to, can I stimulate these receptors with something else? Can I block these receptors so they can't receive norepinephrine or acetylcholine? And once you know the effects of sympathetic nervous system versus the parasympathetic nervous system, if something is agonistic toward that, it's going to stimulate that direction. If it's antagonistic, it's going to push it toward the other direction, right? Or it's going to block the effects. So you're going to get the opposite effect, right? So that's where that terminology comes from. But adrenergic receptors basically receive adrenaline or noradrenaline, right? So that's where the terminology comes from. Cholinergic receives acetylcholine. And then you have subdivisions of adrenergic. You have alpha and beta, and then you can even have subdivisions of that as well. And so with cholinergic, you have nicotinic and muscarinic. Right. So that we usually don't put in there from the get-go. That usually comes up later, but still, it's more comprehensive now. But then you get into the effects, like what does norepinephrine do when it attaches to an adrenergic receptor on, say, the heart? It will increase heart rate. What happens when you attach epinephrine to an adrenergic receptor on the heart? It'll increase heart contractility. So we start listing out effects that you get under sympathetic control versus parasympathetic control. And all these are listed on the PowerPoint too. So we have things like increased heart rate, increased heart contractility. If that's what sympathetics does, then parasympathetics will do the exact opposite, right? So what, and again, this is kind of pushing forward, and we're going to talk about it once we get there. You know, what would happen if the heart receives sympathetic innervation? I would get increased heart rate, maybe increased heart contractility. But what if I wanted to give the patient a beta blocker? Right, then I'm going to decrease heart rate or decrease heart contractility, right? So why would I want to do that? Well, maybe the heart needs to relax better because it's too stiff. Or maybe I need more diastole, more refilling time. So we want to make a longer gap in between two systoles, if you will. So maybe that would be some good functions for a beta blocker. Or another thing that we do with the sympathetic nervous system is general vasoconstriction. And I'll tell you a story about a patient. Patient came into Piedmont, that's in Rock Hill. I think it was yesterday. Can't remember the accident, bad internal bleed. And their sympathetic nervous system had kicked in so much you could see a complete line of where all the blood had been vasoconstricted away from the skin and the extremities. And the torso itself was normal color. But once you got up toward, say, the head, the shoulders, the arms, and then the lower extremities, they were completely blanched white. So that person was going through extreme vasoconstriction because they were losing blood volume internally. They were bleeding internally. So they were basically shutting off all peripheral circulation just to keep the vital organs alive, which was exactly how that sympathetic nervous system is supposed to work. But usually you don't see it to that extreme, you know? So that person had completely become hypotensive, and they had to do something inside the body drastically to bring that pressure back up again. Well, hello, Gracie. How's it going today? You saying hey, or you got a question? Because it'd be cool if you were just saying hey.
Oh, I have a question.
Sure.
So how would you reverse that? What's an example of how you could reverse that?
Yeah, you could give them norepinephrine. You could give them angiotensin 2. Most of the time, they're going to give it, vasopressin if they're trying to help while you're giving them, blood. So you obviously got to return the blood. You got to return, fluid to the system, because that's the main thing that's essentially driving pressure to begin with. So you got to replace the blood, but you can also help with the pressure too. You know what I mean? So a lot of times if people are hypotensive, you want to increase tension somehow. So we want to stimulate the sympathetic nervous system maybe. So maybe you could give them norepinephrine, or I know we haven't got to it yet in this class, but if you remember the renin-angiotensin-aldosterone pathway, right? Two of the strongest vasoconstrictors that exist in the body come from that pathway. And the sympathetics, believe it or not, can actually stimulate renin, right? So most of the time when we talk about the renin-angiotensin-aldosterone pathway, renin gets secreted when the kidney has too little GFR, right? And it doesn't matter how many times we do this. We can do this 100 times and it's still useful. And in the presence of renin, you're able to convert angiotensinogen, which is the inactive version, ogen, into angiotensin 1, which is still pretty inactive. It's just really weak vasoconstrictor at that point. But once it runs through the lungs and it comes in contact with the angiotensin converting enzyme, then you have a pretty powerful vasoconstrictor present. But then the presence of angiotensin 2 in the blood also is going to constrict, efferent arteriole of the glomerulus. So that way the kidney can keep filtering, right? Even though the kidney is not getting nearly as much blood as it should be, we still got to remove waste. So we want to shut off any blood leaving that glomerulus. But the more important things that we're talking about now is we're also going to increase aldosterone production, which is going to hold on to fluid. So we're not losing as much fluid to the final urine product. We're also going to increase antidiuretic hormone. So the presence of this helps maintain fluid volume so it's not going as low. At least, if we're bleeding, we're not also peeing it out at the same time. You can imagine if I got a pretty bad blood flow going, I don't want to pee normally because then we're losing fluid left and right. So we want to hold on to fluid. This also holds onto fluid without affecting sodium levels. And it also happens to be the most powerful vasoconstrictor. So there you go. You could give that to the patient if you're trying to increase pressure. You can give that to the patient if you're trying to increase pressure. At that point, that person was actually employing enough sympathetic innervation that this was already running like crazy, right? This was already running. So he's already trying to reestablish his own pressure, but you got to get enough blood in him, because the reason GFR usually goes down to begin with to run the renin-angiotensin-aldosterone pathway is usually because of a decrease in blood volume, right? And that decreased blood pressure, and the blood pressure goes down, that decreases GFR, right? And once the GFR goes down, that's when renin usually gets secreted. But I could bypass this whole thing if I want to. We don't have to wait for the kidney to tell me to do it. Under a strong sympathetic response, I can go ahead and kick in renin, and that'll start this whole system. So he's got, that person had this going on, which had stimulated that, plus they had this and this all happening at once. So that's trying to create tone, and you could even create more tone if you wanted to, because if they're still hypertensive or if they're still hypotensive, got to tense it up, And so, but fluid volume is what needed to be replaced in that person. But now, this makes more sense, because at first, and I did put this in the notes, when we first learned this, sympathetics is weird, and I'll get to origin in a minute. But when you start to see the list of things that come with sympathetic innervation, like increased heart rate, increased heart contractility, the vasoconstriction makes no sense at all. Why would I want to increase my cardiac output, which both of these would do, right? Because if I'm looking at that, heart rate and heart contractility are the two main things that create cardiac output, right? Because cardiac output equals stroke volume times heart rate, and norepinephrine can increase the heart rate. Epinephrine can increase the stroke volume by increasing contractility, because the more the heart beats, the more vigorously it beats, the more fluid gets ejected, right? Because if the heart's only beating like this, only 70 milliliters is going to leave. But if the heart beats like this, then maybe 100 milliliters leaves, right? See what I'm saying? Or like 135 maybe. So by increasing the contractility, right, more fluid leaves, that increases the stroke volume, right? So if I'm increasing cardiac output, why would I want to vasoconstrict? Doesn't make any sense, because are you not increasing peripheral resistance by doing that? Right? Which is pushing back on the heart. You are, but watch this. When we employ sympathetic vasoconstriction, let's say this is a head, and I know that's very usual looking, but I want to be able to draw inside of these things too. So here's my body. When you have vasoconstriction that's usually stimulated by the sympathetic nervous system, we're usually trying to decrease blood flow specifically to the skin and anything that's very acrally located, distal located. So here would be very specific, here would be very specific, here, here, you know, here, skin, nose, ears, fingertips, toes. Those are going to be constricted first, right? And it'll work its way back from there. So the vasoconstriction will kind of work its way back from there. But have you ever been like cold before? Right? Cold is a stressor. When I'm stressed, guess what happens? You kick in the sympathetic nervous system. What gets cold first? Fingers, toes, ears, nose. Isn't that funny? Because the cold is taking you away from homeostasis. The body sees that as a stressor because the body was built and designed in an environment that's unlike ours. The environment the body was developed in didn't have heaters and blankets, right? It had caves and ice, you know? So when it got cold, it's saying, yeah, we're screwed. You know, that's a stressor to the body. So what it's going to try to do is survive. So it ain't worried about losing a finger or a toe or your ear falling off. It's worried about the vital organs. So by vasoconstricting the skin, which is the largest organ of the body, the distal extremities first, and vasoconstricting back, what that's going to do is that's going to repull blood and give it a greater pressure here, which are the areas that I need to survive. Because if I have thighs, I can run, right? It doesn't matter if I lose a toe or two. So if I'm walking along, I'm real cold, I'm kind of slow and sluggish. I still need to be able to think if a situation comes up. I still need to be able to run if a saber-toothed tiger comes after me. So the body has repulled all its blood to the core, and that's going to keep that blood warmer, right? Because it's further away from the surface, and it's going to increase its perfusion power to these organs. So I can think better, I can get more blood to thigh muscles, I can perfuse the kidneys better, the heart better, so the vital organs stay alive, right? Because you've seen people that have lost all their limbs before, right? And they're still alive, right? Because this part stayed alive, right? So that's one of those things where that's what this person was doing. So that person had lost so much fluid volume that the body's like, well, screw it. If we lose our arms and our legs, you know, they're not going to lose the head, but certainly we're not going to send a lot of blood to the surface like the scalp and the skin of the face. It's very vascular up here. We're just repulling it to the brain, right? It's just going more internal carotid than external carotid, right? So what ends up happening is norepinephrine comes in and it basically shuts down everything. And then epinephrine comes in, it says, I'm going to selectively choose your heart, your thigh muscles, and I'm going to open those back up again for you. So we're getting good pressure in the core, right? But we're not diverting blood everywhere else. So that's what that person was doing under a very strong stimulus, which was death is imminent. You know, that's a pretty strong stimulus. Isn't that cool? Pro, increased heart rate, increased heart contractility, vasoconstriction. Now you can see how those are useful under stress, right? Even though we're not generally stressed like that all the time, that extreme example shows you why it works the way it does, right? But it also explains why do my fingertips and my toes get cold first when it's cold outside, because cold's a stressor and I'm just trying to reroute blood or keep the blood warm, right? It's not worried about losing a toe, it's worried about losing a brain, it's worried about losing a heart and a kidney. So increased heart rate, increased heart contractility, vasoconstriction, but then you have some random things you just have to memorize. But it works if you think about it from an old fashioned perspective, like, I mean, real old fashioned. I'm talking about like clubbing your wife with a stick, old fashioned. So pupillary dilation. And I know we're not cave people. I know Homo sapien, Homo erectus, and all that stuff's different than the Neanderthals, but still, just it works. So pupillary dilation, you got to be able to see better to get out of a stressful situation. Sometimes this will create more alertness, right? If my reticular formation is more active, which more light stimulus would make it more active, then my brain's going to be more active, right? Plus, I can just literally see better, right? So pupillary dilation. So if it's getting dark outside and you're running away from something in the woods, it would be nice to see the tree in front of you, right? Because you run into that, you're done, toast. So increase this, increase that, increase respiration as a whole. So not only am I breathing faster, deeper, to go along with the increased cardiac output, because we really want to oxygenate that blood, it's also releasing glycogen from the liver. It's also releasing glycogen from some of these large muscles. Norepinephrine can do that, right? Well, epinephrine actually does that more, but epinephrine is going to say, all right, we've stored this sugar up in the body for situations where we need it, right? And I need it when I'm starving, like if I'm fasting, and I need it when I'm in an extremely stressful situation. So that's part of respiration. Respiration is not just the breathing, it's also the conversion of sugar into energy. So it'll release glycogen. We'll start to go through, glycogenolysis. That's going to release sugar into the blood. So we have fuel that we can burn. All kinds of cool stuff's going to happen to make the body more efficient to deal with a stressful situation. But at the same time we're doing all this, we can't be wasting time and effort on the digestive system, because anything that's going to be supplied by the digestive system is probably hours away, right? So it's just taking up blood, it's taking up time and energy right now. So we're going to decrease GI motility, decrease GI secretions. And so that explains why sometimes when we take drugs that stimulate our sympathetic nervous system, you get dry mouth and constipation. Right? So again, all of this starts to make sense after a while. And a lot of stuff that you end up doing in healthcare is based off the autonomic nervous system, right? Especially if you do more emergent stuff, like if you end up dealing with bleeds and trauma, you end up seeing a lot of stuff that deals with autonomic nervous system. And so once you understand sympathetic, then parasympathetic is the exact opposite, decrease, right? So part of the increase in respiration is bronchodilation. Dilation. And so part of decreasing respiration with acetylcholine is bronchoconstriction. So while there's rarely a time where I would want to bronchoconstrict something, it's not really implying that we're going to narrow the airway more than I'm just going to allow it to go back to its normal opening. So like, let's say that this is a relaxed airway, this is a dilated airway. Bronchoconstriction is basically just saying I'm going back to relaxed again, right? So it's not really closing it off like maybe histamines would, or release of chemicals from like eosinophils or something like that. It's basically just saying I'm going back to normal, right? But, there's certain drugs that if I don't want to go back to normal, let's try to block acetylcholine then. So if I have asthma, and part of the problem with asthma is this airway has become too narrow, right? There's two ways I can open up the airway. I can either employ sympathetic innervation, right, which will bronchodilate, or I can block parasympathetic innervation, which will also bronchodilate, because it's blocking the natural ability to vasoconstrict. It's saying, no, thank you. Right? So again, learning all these lists are useful. So the more easy to read list we have right here. And I don't know if I put one parasympathetic. Yeah, right there. So with sympathetic, what we normally memorize, of course, is fight or flight. So sympathetic. These are things that will help you run from a bear or fight a bear. And with parasympathetic, you remember rest, sex, digest. right? So increased GI motility, increased GI secretions, right? Erectile tissue, sex, right? Because sometimes parasympathetic, you can use like acetylcholine, they sometimes will cause, will cause vasodilation, but it's more the presence of acetylcholine will release more nitric oxide. So it's actually nitric oxide that's actually doing the vasodilation, but you get the idea. So if I have more parasympathetic innervation, I have an increased likelihood of getting erection. So that's the sex part. And as I'm resting at night, you have decreased heart rate, decreased breathing, right? So at rest and at sleep, people's heart rates really drop. Their breathing rate almost drops in half. You know, so if a normal resting respiratory rate for breathing is like 14 breaths per minute, when you're sleeping, it's sometimes like 7, you know, so it's really chill. But again, this will help you remember some of the things, like what would optimize my body to do this better, right? What would optimize my body to do this better? But again, the initial mistake people sometimes made is they think sympathetic speeds up everything, parasympathetic slows down everything, and that's just not right. Sympathetic makes you better able to deal with stress. Parasympathetic helps you rest better, right? Have sex and digest. So it's not always an up, 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 down, down, down. You know, most of the things with sympathetic, yes, are increased because we're looking at it from like a heart and a respiratory rate perspective, right? But, you know, the GI, of course, you have to remember it goes down. So it's just easier to memorize the lists than it is to try to say everything's too high or everything's too low. But there's various different ways to memorize that stuff. But it should all make sense once you've memorized everything and understand how it works. So origin, let's get into this because this honestly is probably not going to help you that much. About the only thing that we deal with in the real world where this becomes super applicable is when you get into Horner syndrome and you talk about the sympathetic chain ganglia or the paravertebral ganglia. But standardized tests would certainly be able to latch onto these things because they're very specific factoids, if you will. So let me go over these with you real quick. When you deal with sympathetic, like let's say delivery, cord is where sympathetics is going to come from. It's not where it originates. Usually it originates in, like, say, the hypothalamus or the brainstem, right? Like if it has anything to do with heart, vessel tone, maybe medulla, I would think about hypothalamus. If it has anything to do with lungs, pons, medulla, hypothalamus. So ultimately, that's where sympathetics is going to come from. But where is the signal coming from? It's not coming directly from the hypothalamus to the heart. It's coming from the cord. So it'll send a signal down the cord, and from the cord, then it'll go to the heart, right? So when I'm trying to send sympathetic somewhere, even if it's the eyeball, it's going to come from the cord. Isn't that crazy? So if we draw a picture, here's the brain, here's the cord, right? Sympathetics is going to come from here. And the specific places in the cord sympathetics is derived from is not the cervical region. It's in the thoracic region and basically the only parts of the lumbar that have cord. So T1 to L2. So T1 to, let's say, L2 is where sympathetics can come from. And because that's very specific, that's an easy, like, standardized test question, right? So obviously there's places above T1 that I need to send sympathetics to, right? Like if I'm trying to vasoconstrict, how does that get everywhere? Well, it can actually follow vessels. Or if I'm trying to go to that eyeball, you know, how do we get up to the head? If it only starts at T1, we can ride along these things called sympathetic chain ganglia, which will run alongside the cord. So here's the brain, here's the cord. Right alongside the cord, you have this stuff called sympathetic chain ganglia because it looks like a chain in real life. Just looks like little clusters of neurons and then a little connection and then another little cluster of neurons and then a little connection and then another little cluster and then a connection. It literally looks exactly like that in the body. So it's called a sympathetic chain ganglia. So this is our sympathetic chain. or you could call it paravertebral, because that basically just means it runs right alongside the vertebra, right? Which is, of course, housing the cord. So either one works. It looks like a chain. It's running right alongside the vertebral column or the cord. So you can call it sympathetic chain ganglia, or you can call it paravertebral ganglia. And ganglia just means a collection of cell bodies, right? So a bunch of like these guys, right? Here's a soma cell body. Here's another soma cell body. Here's another soma cell body. Here's another soma cell body. You get a collection of these things together that all work on the same thing. You can call it a nucleus or a ganglia. And out in the PNS, we usually call it ganglia. Okay. So if the signal is coming from the cord to get to a target tissue, where does it have to go through? First, it has to go through the sympathetic chain or the paravertebral ganglia. So for example, if I'm going to go to the eyeball, then I'll start at T1, I'll hit the chain ganglia, then I'll go up the ganglia to the eyeball, right? Let's just say it's looking at you or something like that. So I'll have to ride along those ganglia. Okay? But anywho, where in the cord does it come from? Let's look inside the cord. So let's say I take a cross section of the cord and I look down on it, right? I'm looking down on it. And let's say this is the dorsal aspect, which is toward the, so let's say this is cord right here. A vertebra surrounds that, and that side would be the spinous process side, right? Transverse processes, you know, here's the cord, here's like pedicles or something like that. Here's a vertebral body. And this is not to scale by any stretch of the imagination, but again, this is dorsal toward the spinous process, toward the back. This is ventral, right? And this is all within the canal in the middle. So when you look at a vertebra, here's a vertebral body, pedicle, 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 right? And then you end up having a wall on the backside, and the wall itself is the lamina. But out here we have a transverse process because we're in the thoracic region. They're going to kind of stick out here and articulate with the ribs. But anywho, they'll change shape and maybe have different features to them depending on where they are. In thoracics, they just kind of look like that. And then this forms the other part of that back wall. So together, this is called a lamina, where the back end of the pedicles and the transverse processes kind of meet. That's called a lamina. And then at the end of the lamina, you have that spinous process where muscles can attach to. So again, this is a vertebra. Here's a vertebral body, pedicles, lamina, spinous process, transverse processes, cord would be right in here. And it's about that size. So it's not that big. Right. But again, this is facing toward the back. This is facing toward the front. So that's why when you draw a picture of the cord, this is the dorsal aspect because that's toward the spinous process. This is the ventral aspect because that's toward the body, or the belly is ventral. And when we draw the cord the first time, we always draw a dorsal horn and a ventral horn, right? Because we're just trying to show how the body and the CNS are connected. So if I have some type of sensory afferent signal coming in here and a motor efferent signal coming out there, if it's coming directly out of the cells that live in the ventral horn, then usually these are alpha motor neurons and they go to skeletal muscles. But if a signal that's coming out of here originates right here or here, that's called a lateral horn. And not every part of the spinal cord has that, but from T1 to L2, we do, right? So if I'm in the C7 region or C6 region, it might look like this. Right? There's no lateral horn. Like if I'm in, let's say C5, it's just a dorsal horn. It's a ventral horn, right? But once I get to T1, now all of a sudden you have this little lump sticking out the side. It's called a lateral horn, right? So that's where sympathetic starts, or that's where it's going to arise from. And from here, usually I just draw it out here. It actually takes a ride out this way. I'm just going to draw it out to the side just to decrease the complexity of it. So normally it rides down here and it'll follow a certain branch off the spinal nerve, but let's just go from here. So if I'm going from the lateral horn to the sympathetic chain ganglia that lives right out here alongside, right, then this signal that's going from the lateral horn, so we're talking about sympathetic nervous system, to the paravertebral ganglia or the sympathetic chain ganglia, we call the preganglionic transmission. This is preganglionic. And preganglionic with the sympathetic nervous system is very short because we don't have very far to go, okay? From here to the target tissue, this is called post-ganglionic. And in the sympathetic nervous system, this is longer, right? So this is short, this is long. Right? And the neurotransmitter for preganglionic transmission, whether I'm dealing with sympathetics or parasympathetics, is always acetylcholine. So that's what's being secreted right here. But when you get into your postganglionic neurotransmitter for sympathetics, that's when it gets changed to norepinephrine. Okay. Okay, so there we go. Excellent. Parasympathetics, let me do origin real fast. Most parasympathetic innervation is actually going to be coming from cranial nerves, so off the brain, right? The most common cranial nerve that you're going to hear mentioned again and again and again and again and again and again and again is vagus, right? So cranial nerve 10 or vagus is going to carry about 70% of all parasympathetic innervation. So whether it's going to the back of the throat, whether it's going to the heart, the lungs, the stomach, the duodenum, the jejunum, the ileum, the ileocecal valve, the ascending colon, the cecum, the transverse colon, the hepatic flexure, it's all coming from vagus, right? So vagus controls pretty much all of your thoracic and abdominopelvic cavity up until a point, and we'll name that point in just a minute. But parasympathetic primarily comes from cranial nerves, mostly cranial nerves. So for example, here we go. So you can see vagus is responsible for a lot. And then the last little bit of parasympathetic actually comes from these things called pelvic splanchnic nerves, which are arising from sacral spinal nerves. So at the very bottom. So I think, let me find the better picture. I think this one's a good one for that. So here's sympathetic, all coming from the cord, right? Lateral horn of the cord. Here's the sympathetic chain ganglia, the paravertebral ganglia, and then it goes off to its target tissue. So from here to there, it's pretty short distance, right? This is my preganglionic transmission. And what gets secreted right here is acetylcholine, okay? But once we leave the sympathetic chain ganglia and we go to our target tissue, what gets released post-ganglionic is going to be norepinephrine, which that's what we're familiar with sympathetic innervation. With sympathetics, we're always used to talking about norepinephrine. With parasympathetics, we're talking about acetylcholine. But at that time, it's talking about the postganglionic transmission, which is really, in the real world, the only type we want to remember. But on a standardized test, if they ask you, what's preganglionic transmission of sympathetic or what's preganglionic transmission of parasympathetic going to use, it's always acetylcholine. Preganglionic is always acetylcholine. So acetylcholine is going to be secreted here, 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 here. And in parasympathetic, it stays acetylcholine, right? So oculomotor, that's cranial nerve 3, facial, right? That's cranial nerve 7, vagus, that's cranial nerve 10, right? So both pre and post, it stays acetylcholine because we're in parasympathetic. But in sympathetic, pre is acetylcholine, post norepinephrine, pre-acetylcholine, post norepinephrine. And so that gets talked about, pre and post ganglionic transmissions. So I can write that down if you want to. Like when you do sympathetic division of the autonomic nervous system, you're coming from the cord, specifically from the lateral horn of the cord, which will exist from segments T1 through L2. Your preganglionic neurotransmission is going to be acetylcholine. And your preganglionic signal is pretty short because the paravertebral ganglia or the sympathetic chain ganglia runs right alongside the cord. It doesn't have far to go. But your postganglionic neurotransmission, which is the kind that we're always memorizing, in sympathetic switches to norepinephrine. And postganglionic usually has to run a longer distance. Right? That's not hard, right? And then when you get into parasympathetic, most parasympathetic comes from cranial nerves, right? Primarily vagus. This is your, what we call the Benjamin Franklin answer. If you don't know, put vagus, right? Like if they ask you what's in sympathetic, or I'm sorry, what sends parasympathetic innervation to blank and you have no idea, just put vagus, unless it's implying that it's really, really low or toward the end of the colon. And then you would put some type of splanchnic nerve that we just showed. So whether it comes from like S2, S3, S4, who cares? It's coming from a splanchnic nerve. But vagus is your go-to if you don't know. But cranial nerves is where most parasympathetic innervation comes from. What they can't take care of, mostly done by vagus, you have pelvic splanchnic nerves, right? But they're preganglionic, which happens to be, again, acetylcholine. It's longer because literally, if I'm going from the brain all the way down to the stomach, vagus is carrying that most of the way. And then we're going to get to a ganglia right near the target tissue, which is going to be right near the organ itself. So that preganglionic transmission went a long distance. So if you ever do a dissection of a body and you're looking at vagus, you can follow straight down the neck. It's like right alongside the heart. So like here's the heart and you'll have a phrenic nerve right here and there's vagus nerve right there, and it just keeps going and it keeps going. And phrenic will stop at the diaphragm and vagus keeps going, right? It's crazy how long vagus is. It's crazy. But preganglionic is going to be long. Postganglionic, which is still going to be acetylcholine, right? That's what we associate with parasympathetic, is relatively short. And that's the type of questions they ask on a standardized test. Has nothing to do with anything useful, really, for the most part. I mean, it does if you get into like surgery and stuff like that. It's kind of useful to know, but still. But it doesn't give you an overall picture of what's happening in the body very well. So that's what these little things are kind of showing you in the diagram. So the diagrams are actually really nice sometimes. Sometimes the diagrams are just kind of poo-poo, just kind of very generic. But this one's really just doing sympathetics for the most part. So here's T1 to L2, so that's nice, right? Here's my pre-ganglionic neurotransmission, didn't go far. Here's my post-ganglionic neurotransmission, has to travel a little bit further, right? Here's a little slide that summarizes that right here. Sort of. So here's my pre-ganglionic. So whether I'm sympathetic, it's acetylcholine. Whether I'm parasympathetic, still acetylcholine. Postganglionic's here. So with parasympathetic, still acetylcholine, right? With sympathetic, switches to epinephrine and norepinephrine. Most of the time, if you're just doing sympathetic nervous system, it's just norepinephrine. If you're using the adrenal medulla, then it's epinephrine and norepinephrine. That's what this little thing is. That's the adrenal medulla. But still, where did the signal come from that's going to the adrenal medulla? Lateral horn of the spinal cord, right? Because that's where all sympathetic arrives from. Or at least starts, originates. And with Horner syndrome, this basic information helps, right? Like sometimes what Horner syndrome is, it usually starts, well, what Horner syndrome is the presence of three things. That's, when you have a syndrome, it usually means you have a certain number of symptoms that always have to be present in order to be that syndrome, right? So with Meniere's disease, right, in neurosensory, you have tinnitus, gradual hearing loss, and vertigo. Those three things have to be present to be Meniere's disease. It's a syndrome, right? With Horner syndrome, anhidrosis, meiosis, ptosis. So you have a droopy eyelid, you have a small pupil, and you're not sweating on like one side of the face only. That's Horner's syndrome. So where Horner syndrome usually comes from is what's called an apical lung tumor, right? So you have some type of lung cancer, and the lung cancer happens to be really close to the top. So let's look at an apical lung tumor X-ray. Usually you'll see the clavicle's kind of been eaten away. There'll be a little nodule somewhere around it. So at first, my eye's drawn to that little rascal right there. Trying to see if it's anything else other than that, though. At first I was kind of drawn to this. Now I'm more or less drawn to that, right? Look at the opacity right here that exists. Like, look at the color. Very dark, but look over here. Wait a second. this is probably the tumor. And that tumor, well, here's a nice one. Okay, there we go. That's a lot easier. I'm going to lose my license on that other one, right? So here's a tumor for sure. Here's a tumor for sure. That first one that we looked at, I don't know which one it was. Here's a tumor for sure. These are all apical lung tumors. I'm thinking, I don't know where it was now. I'm thinking it was actually, is this one? No, that wasn't it. It was actually that grayish color. So let's look at this one right here and wonder, now how on earth would this have anything to do with, say, sympathetic nervous system? How is sympathetic nervous system going to help me diagnose this? What happens with apical lung tumors is these things will compress the sympathetic chain ganglia up in the neck, right? And when it compresses that sympathetic chain ganglia that's going up, right, up here, I can't get sympathetics to, say, the eye or the side of the face. And some of the effects that we get with the sympathetic nervous system, right, was pupillary dilation. And if I can't get that sympathetic there, that means the pupil can't dilate. So what ends up happening? The pupil constricts, and therefore you end up getting the miosis, right? For the anhidrosis, there's certain sweat glands that are responsive to temperature change, which most of them are, and there's certain sweat glands that are stimulated by something else. And most of the time it's stress, anxiety, or sympathetics, right? Which oftentimes comes out in stress or anxiety. So if I can't get sympathetic innervation to some of those sweat glands, they won't sweat. So you end up getting the anhidrosis, right? So in this case, Horner syndrome is indicative of a patient having an apical lung tumor. That's most of the time what causes it, because it's compressing that sympathetic chain ganglia, and I can't get sympathetic innervation to that side of the face, so they can't sweat on that side of the face. The pupil gets small on that side of the face. It's pointing you toward a good diagnosis. Right? So again, there's some application and usefulness of knowing that sympathetic chain ganglia, where it's located, but because of the way it's set up, it makes it easy for standardized test questions to come in and say, well, how long is the pre-ganglionic neurotransmission? You know, like we care, we really care. You know, who's got a ruler measuring that stuff out in the real world? Nobody. But still, that's where questions like that come from. This little slide right here, it's probably not super duper useful to you, but it does basically imply that, you know, tyrosine is used to make all these fancy substances. So if I have some type of tyrosine metabolizing disorder, I'm in big trouble, because I can't make dopamine, which is going to help me modulate muscle activity. Like, you know, when you have Parkinson's disease, you can't make dopamine. So treating them with levodopa helps. But I also couldn't make norepinephrine and epinephrine either, because you can keep going, right? That's a big deal. But sometimes we'll have drugs that might stimulate, say, norepinephrine to stay longer in a synapse, right? So sometimes those drugs are what we might call SNRIs, like serotonin norepinephrine reuptake inhibitors and stuff like that, but it can also affect dopamine. Some sense of euphoria comes with some of those drugs. But anywho, I'm not going to test you on pharmacology or anything like that. But this just goes over again, sympathetics and parasympathetics. This part right here just goes over the idea of what we talked about before. When you have sympathetic innervation, of course, we know we have increased heart rate. We know we have increased heart contractility, but you're also getting vasoconstriction at the same time. So in a nutshell, what this slide says is when we employ the adrenal medulla, part of the adrenal gland that sits above the kidney, right? Adrenal above the renal. So the adrenal gland, which sits above the kidney, the adrenal medulla is kind of displaced nervous tissue, and it makes catecholamines like epinephrine and norepinephrine, right? And when the sympathetic nervous system is strongly stimulated, what we can do is we can just send a signal to the adrenal medulla, and that adrenal medulla will go ahead and start pumping out epinephrine and norepinephrine into the body in the blood. So it can communicate with all these places all at once. So I might get a dry mouth, right? I might actually start sweating more. I might start sweating under my armpits. I might start sweating on my palms. I might start getting really sweaty, but I'm getting a dry mouth. But my heart rate's increased. My respiratory rates are increased. So sometimes when you get real nervous, all those things happen, right? That's your adrenal medulla kicking out too much epinephrine and norepinephrine. But it's increasing cardiac output. It's increasing our respiratory rates. It's freeing up stored sugar. It's vasoconstricting, so we can increase pressure, all that kind of stuff at the same time. It's allowing all this stuff to happen at once. But when the epinephrine gets out, it's able to selectively dilate where I want that higher pressure blood to go. So what this slide's saying is norepinephrine comes in and it's a general vasoconstrictor. However, when epinephrine comes in, it says, well, I'm going to selectively redilate coronary arteries because that's going to the heart. I'm going to redilate vessels going to the kidneys. I'm going to redilate vessels that are going to the thighs. So that way, if I need to think, or, vessels going to the brain. So if I need to think, I need to maintain pressure, fluid volume, and run. All those things are going to be now the chosen ones of the body. So norepinephrine comes in as a very general vasoconstrictor, while epinephrine can come in and selectively redilate areas where it wants blood to be in greater quantities. So we increase those perfusion rates. Okay. This part, I'm not really going to ask you anything about. It's basically saying that, not only does sympathetic need to travel to all the things we're trying to control sympathetically, it also needs to be able to go to things that we're not really trying to control, but we might want to slow down if we don't want to be wasting energy. So when we're going to the digestive system, we still have to send sympathetic there. Because if I'm in a stressful situation, I don't want a lot of blood going into my digestive tract so I can cramp up. I need it to go to the thigh muscles, the heart, the kidneys, the brain. Right? So sympathetics going to the digestive system has to kind of ride along with some of the other stuff that's going to the digestive system too. So it typically rides along some of those large vessels, like the superior mesenteric artery, the celiac trunk, the inferior mesenteric artery, and it'll meet up with ganglia in that area. But those ganglia are in front of the cord, and they're called prevertebral ganglia. So don't get these confused with what we call paravertebral ganglia. Paravertebral ganglia is the sympathetic chain that we always talk about. Prevertebral are the ones going to the digestive system and stuff like that. So we can inhibit digestive function, so we're not wasting a bunch of time and energy and blood flow to a place that's not useful to us right now. But this is the route they take, so I just color coordinated it. But if you ever hear somebody talking about the solar plexus, usually they're talking about some of these things that are going into the digestive tract. It's an old-fashioned word. So again, this is sympathetic and parasympathetic in a nutshell. And how it can be asked of you. So we'll go ahead and take our normal break here. Endocrine systems, obviously longer, but it's the exact same thing you would have received in Anatomy 2. So the things I want to cover with you specifically is how do we stimulate glands to release hormones? That's important again. This is important again, because sometimes our glands are going to be not stimulated enough. Sometimes our glands are going to be too stimulated. What's doing it? Sometimes we need to be familiar with the local changes or the local factors that are causing glands to be stimulated, because that'll tie into further changes. But again, I'm going to go over this with you again. We're going to talk about the general function of how the pituitary works and how the pituitary receives information to work appropriately. And then from that point, we're going to talk about, in general, here's a hormone. If I produce too much, that's a problem. If I produce too little, that's a problem. So that's where it starts to get into the fancy diseases, like gigantism, acromegaly, Graves' disease, Hashimoto's, Cushing's, Addison's, these are very useful, right? All these things are extremely useful because these are things you're going to see. Probably the ones you're going to end up seeing the most are thyroid problems, too much or too little. So this will give you, not that everybody's going to have Graves' disease, but somebody might have too high a thyroid. And it's probably because they were just prescribed too much, right? Or somebody might have too low a thyroid and maybe they're not being prescribed enough. But because thyroid disorders can basically affect any cell in the body, right? Because it's basically getting into metabolism and metabolic rates, that's something you will run into more often than not. So if we're kind of familiar with some of the signs and symptoms we would see with Graves and Hashimoto's, that's good. We'll talk about Cushing's and Addison's because that's too much or too little, say cortisol, aldosterone, that's useful. Even hyperparathyroidism, because we'll sometimes see high PTH in patients with end-stage renal disease because we can't absorb the calcium because we can't activate vitamin D. And if I'm hypocalcemic, then that's going to increase parathyroid hormone. And why would a patient have too much PTH, and they're tired and they're retaining fluid? Well, is that just a PTH problem or is that something bigger? They probably have kidney disease. So we'll talk about stuff like that, but I'm not going to read every single slide to you. It's pretty straightforward anyway. So we got plenty of time, but let's go ahead and take a break now. It's 11:14. We'll pick up again at 11:30. So we'll take a break till 11:30 and we'll talk about the endocrine system. So let me pause. All right. So finishing up today, going to work on the endocrine system. First thing, I guess we can just describe it as a whole. When you get into physiology, the whole goal is to maintain homeostasis. And it's a lot of stuff that goes into it. Obviously, fluid electrolyte balance is one of those huge things. You have to be able to have the proper osmolarity going on. And a lot of that's controlled by hormones, and so one simple example is if I become too high in blood sugar or too low in blood sugar, those generate what's called local changes in the body, where local means like close to the cells or close to the tissues. It's local to what's receiving blood. And when the body's not getting enough sugar, it's not able to produce enough energy, and clearly we're not going to be able to function for a long period of time if we're not able to produce the ATP that we need. So in homeostasis, we set certain limits, certain criteria. If it gets too high or too low, we're going to have to do something that's going to take it back toward that original set point that we determined was most ideal. So that's the whole goal of homeostasis, maintaining proper fluid electrolyte volume, proper blood levels of organic substances, proper body core temperature, proper pH. So basically all the chemistry works appropriately and at the right rates. And one system that, of course, communicates and coordinates lots of bodily functions, so everything can kind of work harmoniously together, of course, is the nervous system. The other system that helps us communicate and coordinate bodily functions and parts together is the endocrine system. And the simple difference between how the nervous system works versus how the endocrine system works is the way the chemical communicator gets transmitted or released, or what it's released into. And with the nervous system, you basically have neurotransmitters being released from synapses, which are very close to the target cell. And you have to wire all that stuff together ahead of time, right? So if I want very individualistic control, the nervous system is absolutely the best route to go. But if I need to do something from more of a global perspective, then the endocrine system might be a better route to take, because the endocrine system is primarily composed of glands and hormones and the different parts of the brain or body that control those glands and hormones. And when the gland releases a hormone into the blood, now it's basically there for everybody to see and receive if you happen to have a receptor for it. So things like thyroid hormone, for example, we'll mention that one a lot, is essentially received by every single cell in the body. And it helps the individual cells maintain their proper metabolic rates, and that's kind of everything. So If I have too much or too little thyroid hormone, that's a big deal. But a simpler example, because that's everything that I was mentioning before, is things like blood sugar levels. Like if my blood sugar is just too high or my blood sugar is too low, then that's going to stimulate a very specific organ. And this is all set up ahead of time, and the pancreas is responsive to that. And if I'm hyperglycemic, the pancreas can respond with a hormone that can take that level back down again. Or if my pancreas happens to know that we're hypoglycemic, then it can respond using a different hormone, right? And then that can take the levels back up again, right? So we're always trying to head toward homeostasis. So again, you have to be able to detect changes in the body. You have to have some type of original set point determined, and then you have to be able to take things back toward those homeostatic set points. And again, between the nervous system and the endocrine system, this is how we control and communicate and coordinate all those different functions. So big difference, again, between nervous system and endocrine system is endocrine system is going to use hormones produced by glands. The hormones will go into the blood. And from there, their target tissues will respond accordingly, maybe by increasing the rates that they're doing, maybe change what they're doing, decreasing the rates and things they're doing, and so on and so forth. So a lot of the basics of the endocrine system, same as before. I do want to talk about this one real fast, but let me go back and talk about steroidal hormones real quick too, because this does come up sometimes. Two main categories of hormones, right? You have so hormones are basically chemical communicators released into the bodily fluids. We're just going to say blood for the most part, by glands. And hormones we can put into two categories. You have what's called steroidal hormones, and you have non-steroidal. Simplest division is always the easier one to remember, right? So between the two, the one that contains more hormones is the non-steroidal, because you have ones that are protein based, some that are what's called amine based. So it might just be a couple of amino acids joined together. You have some that are just derivatives of amino acids themselves. Peptide hormones, those belong to the non-steroidal group. So this list can end up being pretty long. And sometimes they'll even get into how many amino acids long is this particular substance. I think growth hormone is like 99 amino acids long or something like that. Don't quote me on that, even though I'm teaching the class. But when you get into the steroidal group, this is a much shorter list. So anytime you have something that's divided into two major groups, memorize the short group. If it's not part of that group, you know it's part of the other one. It saves you a lot of time and effort. So normally that's why we do this part right here. So if I'm trying to memorize all the different hormones, what families they belong to, memorize the steroidal hormones first, because in the simplest rendition of this, you basically have hormones that are either coming from the adrenal cortex, which isn't going to be a super long list. I mean, that's where it gets hard. It can be a long list, but we can put them into families and we can talk about the most important of that family. And then you have the gonads. So these are going to be the glands that produce the hormones that belong in the steroidal family. So if it's coming from the adrenal cortex, assume it's going to be some type of steroid. If it's coming from the gonads, it's going to be some type of steroid, right? So for example, with the gonads, you have things like testosterone, you have estrogens, and progesterone. So those are steroidal hormones. And a lot of times when people hear the word steroids, one of the first things you think about is anabolic steroids. And one of the most famous of the anabolic steroids is testosterone, right? And so when people used to lift weights and they wanted to get bigger, since one of the main functions of testosterone is to increase lean muscle mass, that's certainly a good way to do it, right? So there was plenty of testosterone usage at the gym I used to go to, and I've taken testosterone before, like T250, T400, and Sustanon, and all that kind of stuff. And I used to take lots of different steroids because that's what I wanted to do. I wanted to be big and strong, and I wanted to get bigger. So that's one of the most famous of the anabolic steroids, right? But that also messed with me a little bit too, because sometimes when I was early in like healthcare and I was pre-med back in college, and some of the teachers would talk about using steroids as treatments and stuff like that. I'm like, why on earth would somebody have rheumatoid arthritis and they want to get muscles? I don't understand this. Or why do they have this autoimmune disease? And why are you giving them steroids? How does that help? Because I only knew of really one type, you know? And so I was a meathead. I was just basically familiar with testosterone and other types of anabolic steroids, but there's more than just that. You know, some postmenopausal women might be receiving estrogen replacement therapy, and we'll call that steroid therapy, right? Because it falls under a group of steroids, right? So steroids are talking about a classification based off their molecular makeup. You know, they're cholesterol-based drugs usually. So they're part of the lipid category. Non-steroids are not, right? So they don't diffuse into cells the same way. They're not fat soluble, right? They're usually made up of amino acids or proteins, or maybe even a combination of amino acids and carbohydrates. So that's where the categories come from. It's kind of the molecular makeup, but I was only familiar with one type. So the kinds you're going to hear about the most probably in healthcare are some of the ones coming from the adrenal cortex, like say aldosterone, right? Which is a mineral corticoid. It's a steroid coming from the adrenal cortex, and it has to do with certain mineral levels in the body, like sodium and potassium, maybe, because in the presence of aldosterone, which I know you can't read my writing right there, aldosterone increases sodium reabsorption rates. And by doing that, it keeps water, and it increases potassium secretion rates into the renal tubular system. So basically that means we're keeping sodium and we're kicking out potassium like we normally see in most urine, right? You know, so aldosterone's in charge of that. So it's kind of controlling some of the mineral levels of the body. It's a steroid hormone that comes from the adrenal cortex. So aldosterone is a very famous, what's called mineral corticoid, right? And then the other type of steroid you're going to probably hear about the most, right, is some form of cortisol, right? So prednisone, hydrocortisone, right? Some type of cortisol derivative of artificial version of cortisol. And that's sometimes referred to as a glucocorticoid because it also helps with sugar metabolism. It's also known as a stress hormone. So sometimes it'll make you overeat because it'll basically help the sympathetic nervous system deal with stress. And it's going to say, all right, here's all the sugar that I can manage for you. But now that we're low, I'm really, really hungry. So I'm going to start eating more. So cortisol, the usefulness of that, though, in healthcare is it's a very strong anti-inflammatory drug. So it can be used for pain and inflammation. So if you got a massive amount of swelling or a lot of pain, then cortisol might help, right? And it decreases immune function too. So if you have some type of autoimmune disease, right, that's causing inflammation, then they might give you a steroid to treat that. So again, when I was in school, I was like, oh, steroids, testosterone. But, you know, sometimes if they are talking about steroid therapy and it happens to be dealing with, let's say, some type of disease where the body's being broken down, maybe they are talking about anabolic steroids. That's possible for sure. You know, like if I have some type of muscle wasting disease, then they might actually be giving you anabolic steroids as a treatment. But most of the time when they're talking about steroids, they're talking about probably cortisol, most likely, right? So if I'm trying to treat, you know, autoimmunity, pain and inflammation, then cortisol is usually what they're referring to. Okay. But again, this is just kind of listing things out so you know the families. So the other thing that sometimes comes from the adrenal cortex are things called androgens, which are pretty similar to testosterone in nature. So things that make you more manly, right? Andro, man, gen, formation of man. So yeah. Like we're going to start doing, you know, moga in the morning, and that's going to start producing more androgens. That's what I'm going to advertise at least. I learned in business that there's kind of rules out there, but they're pretty lenient when they you know, notice that you're breaking them. So you just break them until somebody tells you to quit. So I'm gonna be like, yeah, we produce lots more testosterone after moga. See where it goes. So that's one thing that's useful. Another thing that's useful, because it's oftentimes going to end up having to do with why we're secreting these hormones, is talk about different ways glands know when they're supposed to secrete their hormones, right? So obviously we need to have good control mechanisms of the endocrine system, because some of these hormones can target and control the rates and activities of almost every cell in the body. Some of them might only control one type of cell. Some of them might only control one type of response. But again, you have to be very careful, because even the slightest changes in blood sodium or potassium levels or calcium levels or glucose levels can really mess you up. So we have to have strong control mechanisms. So how do glands know when they're supposed to release hormones and when to stop releasing hormones? It's usually through these different stimuli. Okay, so 3 ways hormones get released is usually through some type of tropic hormone telling it to be released, some type of direct neural stimulus telling the gland to release a hormone, or the gland is releasing a hormone in response to some type of local change. I think this one will probably come up the most in the real world. This one is going to be the most common reason. And you can have overlaps of these things too, right? There's certain overlaps of some of these things. But it's not like if I'm normally controlled by a tropic hormone, that means that's the only way I can be controlled. I can also be controlled by a very strong local change, right? So anywho, let me just talk about those. So how do glands know when to release hormones? So how do glands know when they're supposed to release their hormones? Direct neural stimulus is the easy one, so that's the one I usually do first. And the best example of that is the adrenal medulla. So here's a kidney, right? Here's the adrenal gland. The middle of that adrenal gland is the adrenal medulla. So pretty simple terminology. You got a gland that sits above the renal part of the body, so we call it adrenal or suprarenal. In the middle of it, we call the medulla. So the adrenal medulla will basically be stimulated by sympathetic innervation. Oops, let's say that's the lateral horn right there. Something like that. So lateral horn, adrenal medulla, kicks out norepinephrine and epinephrine or adrenaline, right? Easy. So how did the adrenal medulla know when to kick out norepinephrine and epinephrine and noradrenaline and adrenaline? It had direct neural stimulus. Isn't that simple? Next example. So there's one. 2, through response to what's called local changes. Local changes are typically going to be changes in blood levels of certain substances. So it could be ions, it could be organic molecules like sugar, right? Something like that. Ions could be things like sodium and potassium and calcium, right? Obviously glucose. So when you get into things like hyper and hypo, any of these things, those will act as local changes. I mean, it's not the only type of local changes. Maybe you'll start to get hypoxia. Hypoxia could be a local change. And but again, when you're getting into the endocrine system and how do some of these glands know when they're supposed to release a hormone, the blood is telling them by some type of substance in the blood that they happen to also be monitoring. So for example, if I'm hyperglycemic or hypoglycemic, then the gland involved is the pancreas. And if I start to notice that I have too much blood sugar, the pancreas is going to release a hormone that's going to take blood sugar levels down, right? So it's going to release insulin. And if it's a strong signal of hyperglycemia, then more insulin, right? If it's a weak signal of hyperglycemia, less insulin, something like that. But once the hyperglycemia disappears because we've taken control of it, then that's the signal for the pancreas to stop releasing insulin. I mean, in a nutshell. And vice versa, if I'm hypoglycemic, the pancreas can also recognize that. And instead of releasing insulin, it's going to release glucagon. And glucagon can increase blood sugar levels, right? Because if I have, say, stored sugar, I need to let it out somehow. So maybe we could do what's called glycogenolysis. Glucagon can stimulate that, right? Or, Oscar. Or if I'm trying to make new sugar out of something that's not sugar, We might call that gluconeogenesis. Glucagon can stimulate that too. So glucagon's usually stimulated in times where we're fasting, right? So I can maybe convert fat into sugar or even protein into sugar, non-carbohydrate sources into sugar. But when does the pancreas stop releasing glucagon? Whenever this disappears. So these are examples of local changes. So same thing with hyper and hypo natremia, hyper and hypocalcemia, right? And so hypercalcemia, think maybe calcitonin and thyroid hormone. If I'm hypocalcemic, maybe think parathyroid hormone, right? And you can even do sodium and potassium, like if I'm hyponatremic or hyper and hypokalemic, maybe aldosterone production will change. Right? It's not the normal way I normally release aldosterone. Aldosterone is usually released in the presence of angiotensin 2, right? But if I'm hyperkalemic, like I have too much potassium, then that's a secondary stimulus for aldosterone production because that will help get rid of extra potassium. Right? So that's another way, is through local changes. And then the third way we stimulate glands to release hormones is through other tropic hormones. And you can stop glands from releasing hormones through maybe inhibitory hormones. So some glands are controlled by other glands, right? Or other parts of the body by releasing certain chemicals. So when you get into the first examples in the notes of important glands and the products they release, it talks about the pituitary first, because the pituitary is very famous, right? And it's receiving all of its signals usually from either the blood or the hypothalamus, typically the hypothalamus, which sits right above the pituitary. So this is hypothalamus, infundibulum, anterior and posterior pituitary right here. And in your anterior pituitary, you have all these clusters of certain cell types, right? And each cell type is responsible for a different hormone. So thyrotropes make thyroid stimulating hormone. Corticotropes make adrenocorticotropic hormone, right? Somatotropes make growth hormone. Gonadotropes, right, will make the follicle stimulating hormone and luteinizing hormone, right? And the mammotropes will make prolactin. So all these hormones, thyroid stimulating hormone, adrenocorticotropic hormone, growth hormone, follicle stimulating hormone, luteinizing hormone, and prolactin are all made by the anterior pituitary. And who tells the anterior pituitary when to kick these things out? The hypothalamus, by releasing some type of tropic hormone, right? So hypothalamus might release TRH, which is thyrotropin releasing hormone, and that'll stimulate the thyrotropes to release thyrotropin, which also happens to be called TSH, right? So TSH, the other name for that is thyrotropin, because it's going to go stimulate the thyroid gland. So that will go into the blood, right? And as TSH is going into the blood, it'll eventually make its way to the thyroid gland, right? And when the thyroid gland receives TSH, guess what? TSH is also going to be a tropic hormone. So when the hypothalamus releases thyrotropin releasing hormone, that's a tropic hormone that's going to stimulate the thyrotropes of the anterior pituitary to release TSH into the blood. TSH also happens to be a tropic hormone, which is going to stimulate the thyroid gland to release its hormones, which is going to be T3 and T4. And then once there's T3 and T4 floating around in the blood, that'll send feedback inhibition to the hypothalamus so it can shut down, producing TRH and TSH. So we have all these systems set up. So again, we can respond to stimulus, just like the nervous system did. You know, what's the nervous system's general role? To respond to stimulus. What's the endocrine system doing? Responding to stimulus. So it's no different, really. So when you get into all the different parts and pieces of the endocrine system, the big idea is to know where's it coming from, you know, what's it producing, and then what does it do? So anterior pituitary gets talked about a lot because it makes and produces a lot of hormones. And those hormones will then go on and control other glands. Right? Not all of them. I mean, of course, growth hormone can pretty much affect any cell in the body. But thyroid stimulating hormone is meant to stimulate the thyroid gland, and adrenocorticotropic hormone is meant to stimulate the adrenal cortex, right? So normally this is a little bit past the point, but again, if you understand what the word tropic means, it makes your life easier. So tropic can have two meanings. It can mean to stimulate, or it can mean to increase growth. And sometimes it means both. So early on in life, adrenocorticotropic hormone was used to make your adrenal cortex mature. Later in life, it makes your adrenal cortex kick out more hormone like cortisol, right? But if I produce too much adrenocorticotropic hormone, then I could end up with Cushing's, and I could have too much cortisol and my adrenal gland might be enlarged, right? But again, this helps. So if it's got the word tropic, tropy, tropin, trophy, any derivative that sounds anything like that, trophin, tropy, tropin, anything that sounds like that means stimulate or grow. So context, we usually give it away, but it can mean both. If I oversecrete too much tropic hormone, it'll make that gland or those clusters of cells grow too big. Like if I produce just too much TSH, too much TSH, too much TSH, and too much TSH, then your thyroid gland is going to get bigger, right? I say, whoa. So anyhow. So once you get into the glands themselves, oops, wrong button. Learning the hormones, their abbreviations, their AKAs are always useful. So in the pituitary, since we're producing so many, we learned that the anterior pituitary is subdivided into different cell clusters, like mammatropes, thyrotropes, corticotropes, gonadotropes, and then when you memorize what they make, right? And it makes sense because FSH and LH are going to stimulate the gonads, right? And it's going to stimulate the gonads to maybe make or mature sex cells, or make and release sex hormones, or the corticotropes, which is part of the anterior pituitary, is going to make more adrenocorticotropic hormone, which is going to stimulate your adrenal cortex to make more cortisol, right? Or thyrotropes are going to produce more thyrotropin, also known as thyroid stimulating hormone, which is going to cause your thyroid gland to make more T3 and T4, right? Mammatropes are going to stimulate the mammary glands to produce milk, right, through prolactin. And somatotropes are going to make somatotropin, also known as growth hormone, which is going to make the body grow, right? Body grow. So endocrine at first seems hard because you're memorizing all these glands, their hormones, and every hormone's got an AKA. Hold on. Let me make sure I'm actually sharing screen with you. I really haven't been on more than one slide. So I was on this slide as I was talking. So for example, again, if I'm talking about the gonadotropes, these are cell clusters within the anterior pituitary. And the gonadotropes are making hormones that stimulate the gonads, which are, in a reproductive chapter, the primary sex organs. So the ovaries and the testes, right? I'm stimulating, right, them to start producing. And what do the primary sex organs do? They make sex cells, or they make sex hormones. So it's two different roles. So two different hormones control that. Right? Corticotropes, again, make adrenocorticotropic hormone to stimulate the adrenal cortex. So again, at first, you're learning all these hormones, and they're coming from these glands, and they have all these different names and AKAs and abbreviations, but it ends up being kind of useful because it's partially telling you what they do. So the trick is at that point is once you memorize the gland that's responsible for the hormones, the role of the hormone themselves, why did it get stimulated, right? What would happen if I produced too much? Or what would happen if I didn't produce enough? That's the goal of endocrine. And endocrine ends up being a vital chapter to learn. I put it in the top 3. I'm always just kind of, who's number 1? Cardio for sure, right? Followed by urinary. And I put respiratory with cardio because sometimes there's not a separate section for respiratory, right? Respiratory is a weird chapter. It's one of those ones that's it's got its own division of people that work on it, the intensivist, the respiratory therapist, and they don't blend well, do they? They don't mix well. No offense if that's what you're doing, but they're their own thing. They got their own club, their own members only jackets and stuff. But I put cardio and respiratory together. Urinary, endocrine, those are your top 3 of the most useful chapters you ever get. Unless you're going to be like an orthopedic surgeon or something like that, or you're just going to play with sprains and strains all day long. But still, if patient history comes in, you're responsible for it. And if they got multi-system dysfunction, these are the 2 I'm looking at. If this is too high here, too low here, and too high here, it's got to be one of those. It's either a hormonal issue or a kidney issue. So they're definitely in the top 3. But if you can memorize, why should a gland start producing something? Why would it start overproducing? Maybe there's a tumor. Sometimes if I'm producing too much, it's probably a tumor or an adenoma. Because if the gland's getting bigger and it's losing its normal control mechanism, sometimes it just starts kicking out too much hormone, right? Or maybe there's something missing, in the body where I should be absorbing dietary calcium, but for some reason I'm not anymore. So what are we going to do? Well, let's steal it from our bones. So maybe I'll start producing too much parathyroid hormone. Right? So when people have chronic kidney disease, again, they're going to have high PTH levels. And it's not because there's something wrong with the parathyroid glands. They're working just fine. But we can't activate vitamin D anymore. So I can't absorb dietary calcium anymore. So we're just going to rob it from the bones. And that's going to have consequences, and we're going to have osteoporosis and weak, brittle bones and a bunch of fractures and stuff like that. And why would I be producing too little? Maybe I had some type of congenital growth problem. Maybe early on in life, it just didn't develop. So maybe you have what's called hypopituitarism, or just an inadequate amount of hormones being produced by these glands. But for whatever reason, we're producing too much or too little, there's going to be consequences in the body, and we need to be able to recognize those signs and symptoms, right? So anytime you look at the PowerPoint, that's all it's doing. It's just showing, here's this hormone, what's it normally do, and then what would happen if I produce too much or too little, right? It's not hard, but like once you get into gigantism and acromegaly, it's same cause. It's just usually an age thing. Like if I have gigantism, it's usually coming from a pituitary tumor, a pituitary adenoma that started kicking out too much growth hormone very early in life. And essentially your growth plates just didn't close, because it's normally a lull in growth hormone that causes growth plates to seal when you're about 18, 19, 20 in long bones, right? But if I have a pituitary tumor that's kicking out too much growth hormone, then the growth plates might not close for a long time, and you just keep growing and growing and growing, right? But then you get into acromegaly, which is another condition, and naturally it's usually caused by a pituitary tumor, and you're producing too much growth hormone, but it's after you've already fused your bones. So this is a disease that's acquired in adulthood only, not in childhood, right? So acromegaly naturally is caused usually, again, by a pituitary tumor kicking out too much growth hormone, but it didn't start until you were an adult. And your growth plates have already closed, so you're not going to get taller, but certain places that are still responsible to growth hormone, like maybe some of the flat bones of the skull, maybe things that were highly cartilaginous, maybe things that develop through intramembranous ossification, they still grow. So different parts of the body get large, but not all parts of the body. So things that are acrally located, like hands, feet, head, so you get the prognathism, the big square jaw, the big nose, the big ears, the big forehead, and hands and feet. But same cause here, too much growth hormone, different times of life. That started in childhood, that started in adulthood. Graves' disease, too much thyroid hormone. And if thyroid hormone controls basal metabolic rates, that pretty much could change every single thing in the body. But what's going to be most noticeable first? Maybe I'm burning through energy too fast, right? So energy comes in the form of ATP and heat. So usually they're not going to like warm environments because they're already too hot. So they sweat all the time. They don't like to be hot. They're fidgety. They're very aggravated. They have a lot of weight loss. So it's hard for them to maintain weight, right? And then sometimes you're gifted with something that will stand out in that patient, like exophthalmia. And of course, the new term for exophthalmia is thyroid eye disease, because apparently the pharmacology companies get to name everything now. Right? But exophthalmia or exophthalmos is what we used to call the bulging of the eyes. Now they call that thyroid eye disease. So that's a gift, because if you see that in a patient, you're like, hey, that's a thyroid issue, too much thyroid hormone. Right? But again, this all makes sense. Right? This all makes sense. So what about if I had too low a thyroid? It's going to be the exact opposite. So instead of losing weight because I am burning through energy too fast, I'm gaining weight because I'm burning through energy too slow. I become slow, sluggish, tired. Even the digestive system slows down, right? The nervous system slows down, right? And some nice things about Hashimoto's, which is, again, it's not the only type of hypothyroidism, it's the most common, is whenever hypothyroidism leads to myxedema, which is clinically visible hypothyroidism, sometimes certain things will stick out and it'll help you identify it. So in hypothyroidism, a lot of times they get bags under the eyes, which is kind of like the periorbital edema. It's not unique to hypothyroidism, but it's a nice observable feature, and the lateral part of the eyebrows start to fall out. That's nice, not for the person, but for you to identify it, right? So they start to lose that lateral 1/3 of the eyebrows. So that helps you diagnose it, recognize it. So here's a person before, after, right? Before, after. Cushing's, too much cortisol is usually the problem. Could be, again, pituitary adenoma, where the pituitary is kicking out too much ACTH, and the ACTH is causing the pituitary gland, which is producing the ACTH, is overgrown. It's causing the corticotropes within the pituitary gland to produce too much ACTH. The ACTH is going into the blood and causing the adrenal cortex to start kicking out too much cortisol. So with Cushing's, there's, again, very prominent features, signs and symptoms that will very easily help you diagnose this thing. To me, this is one of the most easily diagnosable endocrine conditions because it's so almost textbook. Every time it pops up, you get the moon face, abnormally round face. There's a difference between a person that's gaining weight naturally versus a person that's gaining weight with Cushing's. The weight tends to always stay around the face and the trunk. So they get what's called truncal obesity. I can write that down if you want me to. Truncal obesity, where most of the weight tends to stay around the torso, but the arms and the legs seem to be kind of neglected. They seem normal in size, maybe even very fit, right? And the moon face tends to basically imply that the face is very round, and you start to get what's called supraclavicular fat pads and a buffalo hump. So when you see it from the back, I don't know if I got a picture of that. So here's some Cushing's right there, the very dark purple striae, very truncal, obese. So most of the weight's kind of staying here, right there. Look at that super round head and face, right? That's moon facies. If it's female, probably facial hair will start growing, so they'll get hirsutism. I can even actually see a little bit of gray right there. She probably shaved it, I'm guessing. See that little gray right there? Right? But hirsutism, they'll get the sideburns will start to grow in further. The mustache will start to develop, and they'll get a lot of whiskers down in the chin. So that's called hirsutism when you see that in a female, facial hair growth in the female. Here's the buffalo hump. Supraclavicular fat pads, moon face. So she's probably wondering, hey, I'm on a diet, work out all the time, I'm gaining weight. Why? Right? So it's a very observable condition. But real quick, let me go back, and I do want to touch on one slide in here because there's a way to help you memorize adrenal cortex and its roles and functions. And of course, Addison's disease and Cushing's disease both have something to do with the adrenal cortex, so that's good to know about. So here's your kidney. Here's your adrenal gland. Adrenal medulla we already talked about with norepinephrine and epinephrine, controlled by direct neural stimulus. We can throw that in with the sympathetic nervous system if you want to, the adrenal medulla. But the adrenal cortex is firmly within the endocrine chapter, in the endocrine system, right? So the adrenal cortex is just the outer portion of the adrenal gland. So let's draw the adrenal gland real big now, just the adrenal gland without the kidney. I'm just going to draw the adrenal medulla real small. We're going to shade it out so we're not paying attention to it. Now, here's the adrenal cortex. So the word cortex just means outer covering, right? Medulla means middle. We're not worried about the medulla. But this outer cortex part, you actually can subdivide into 3 layers or zones. Each zone is going to be responsible, smeared, for different category or family of hormones. So you have zona glomerulosa, zona fasciculata, and zona reticularis, which is nice because it'll form a GFR, which is something that we talk about in urinary, right? It doesn't mean glomerular filtration rate. In this case, it's talking about the 3 zones of the adrenal cortex from outer to inner. So that helps you remember 3 layers of the adrenal cortex: zona glomerulosa, zona fasciculata, zona reticularis. GFR, right? And each zone is going to be responsible for different things. Like zona glomerulosa is going to make cortisol. I'm sorry, is going to make aldosterone. Sorry about that. Zona fasciculata is going to make cortisol, and zona reticularis is going to make the androgens. So we kind of already know the role of aldosterone. Again, we've seen it a couple of times in urinary, back in anatomy 2. Aldosterone does 2 main things. In the presence of aldosterone, so if I'm increasing aldosterone production, that will increase sodium reabsorption rates. So, which means I'm going to keep it because it's affecting the renal tubular system. And if I reabsorb out of the tubule, that means it goes back into the blood. So we're going to keep it, right? And by keeping sodium, water follows. So it's how we retain fluid, water, right? And at the same time that I'm increasing sodium reabsorption rates, I'm going to have to kick out potassium because we can't just keep positive everything. You know, we're going to get rid of potassium. So that's normal because potassium is an intracellular ion. We don't need a lot of extracellular potassium anyway. So we're going to kick out potassium. So increase potassium secretion rates. Okay. So aldosterone is controlling minerals. So we sometimes can call these things like salts. You know, like if you mix it with like chloride or something like that, sodium chloride, potassium chloride is a salt, you know, chemistry. So your outer zone of the adrenal cortex is responsible for salts in the body. So we call those mineral corticoids. Okay? So salts are minerals. The next zone in has to do with cortisol production, and increased cortisol production, again, helps change glucose levels in the body, makes them more available, and then it sometimes makes you hungry to replace them. So it makes you really hungry for real fatty, sugary foods, right? So that's what can lead to weight gain if you have too high cortisol levels, because we're releasing stored sugar, which really isn't being held against you. It's stored in the liver and the skeletal muscles primarily. And when we burn through that stuff, we get really, really hungry. And so when we start to replace it, we get real hungry for calorie dense foods, so fats and sugars, right? So increased cortisol levels really high can actually make you gain a lot of weight, even though you're burning sugar. So it seems controversial at first, like this doesn't make any sense, but it makes sense if you think about it. Because if I burn through all my sugar, what am I going to want to do? I need to replenish it. So I'm going to get hungry. So again, with the Cushing's disease, where I'm producing too much cortisol, that's why they're gaining that weight so fast. And it's also holding on to fluids, and yeah, so it's going to actually increase aldosterone levels too, and you'll hold on to fluid. And anywho, but because it's helping us control sugar levels, we call these things glucocorticoids. So that's what's coming from the kind of the middle layer is the glucocorticoids. And then the innermost layer, which we're going to have here, has something to do with androgens. And so there's a little mnemonic that reminds us, well, which layer has to do with minerals, which layer has to do with sugar, and which layer has to do with sex hormones, like androgens kind of help deal with testosterone production. So there's a mnemonic that goes GFR, salt, sugar, sex, right? Where it's not sexed, but sex, right? So salt, sugar, sex, zona glomerulosa, zona fasciculata, zona reticularis makes aldosterone, which controls certain salt levels like sodium and potassium. Zona fasciculata makes cortisol, which is a glucocorticoid. It helps to deal with sugar levels. And zona reticularis makes things called adrenal androgens, which early on in life is sex determination. So increase androgen levels at birth and during fetal development will make the male descend the testes and turn more male, right? So sex determination, but it's just a useful mnemonic. So if I end up having some type of tumor in, say, the pituitary that causes too much ACTH production, that can then start causing things like your adrenal cortex to kick out too much hormones. And that's what's happening with Cushing's, is too much ACTH will actually kick out too much cortisol. And that cortisol levels will start causing a lot of the signs and symptoms that we end up seeing with Cushing's disease. But you can also have a tumor on the adrenal cortex itself in your middle layer, your zona fasciculata, and that'll cause Cushing's. Or you could just be giving too much steroid treatment, and that'll cause Cushing's, right? So Cushing's is always Cushing's. It's just too much cortisol. But where does it come from? We can determine through different types of blood tests or just basic, common sense. So if I'm giving the patient too many steroids, they can start to have signs and symptoms of Cushing's, like weight gain, right? But again, where's the problem with Addison's disease? Addison's disease is a aldosterone problem, right? So Addison's disease, oops, let me share a different slide with you, is too little aldosterone, right? So maybe the problem is with the adrenal cortex, right? But regardless of where the problem's coming from, what's going to happen with Addison's disease? Well, if I can't produce enough aldosterone, then I can't reabsorb salt. And if I can't reabsorb salt, I can't hold on to water. So one of the big signs and symptoms of Addison's disease is they're always salt craving, and they have what's called orthostatic hypotension. So every time they change position, like go from laying to sitting up or sitting to standing, they feel like they're going to pass out because they can't hold on to that water, because they can't hold on to the salt. So they're constantly craving salt, right? Because they're not keeping it, right? And if I can't keep the salt, I can't keep the water. So they end up getting the orthostatic hypotension. And then because if I get too much stimulation of some of the pigment cells in the skin, they start to get different colorings. So the patient's noticing the orthostatic hypotension. That's what they're complaining about probably. But you might start to notice this little band of hyperpigmented cells across the eyes, or maybe the palms of the hands, or even the creases of the hands. So if they start to get an orangish color, that's something that'll give away that they have Addison's disease. Okay? But anywho, that's pretty much all there is for endocrine. It's not a hard read, to be honest. You're just kind of memorizing pretty straightforward situations where, again, here's a gland, and the gland's responsible for producing a hormone. What does the hormone do? Well, if it's going to maintain our basal metabolic rate, then what can I expect if I'm producing too much or if I'm producing too little? That's endocrine in a nutshell. So that is not the worst chapter in the world. It's a lot of literally memorization, but I think it's set up pretty easily. So that concludes all the information that we needed for our first exam. So first exam again, let's try to get it done by the end of the weekend if you can. So June 18th should be Sunday, I believe. I didn't set up the test itself to actually close at that time. It should stay open, but if you try to take it after June 18th at midnight and you can't get in, just email me and I'll open it back up again. But I did set a date on it just because that's a requirement for the course for me to do that. But your lecture 1 exam, 50 questions, multiple choice, you'll have 50 minutes to complete it unless you have accommodations, and it will go all the way back to fluids and electrolytes. So fluids, electrolytes, neuro, which we covered quite a few chapters, neurosensory, autonomics and endocrine, that will be all covered on our first exam. If you have any last minute questions, then join me Thursday morning at our normal meeting time. Today's meeting, I will replace this Zoom meeting with a Zoom recording as we've done previously. If you've missed any of the previous meetings, they're all recorded and posted here, 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 right? And today's will go right here. So again, I'll be on at our normal time. This will be our Q&A session since we've covered all the material that we need to cover. Come in with any questions that you might have. If you don't have any questions, you don't have to show up. And this isn't the only way to ask questions. If you have questions between now and then, email me. If you have questions after the Zoom Q&A, email me and I will still get back with you as quickly as possible. But this is a way that you can verbalize the question if you want to and get a direct answer at that time. So Zoom Q&A meeting Thursday, 10 a.m. and I'll stay online until people disappear and then I will log out. So probably won't be any recording from this unless I just deem that it's absolutely necessary that everybody hears that question and gets an answer. But again, come prepared for that with any questions that you might have. But don't wait. Email me if you have a question that comes up prior to that. But I will go ahead and end it for today so the recording can go ahead and stop and start consolidating.